Yes, well, thank you very much for inviting me, organisers, for today. It's a very privileged specialty to be part of transplantation, and I'm also lucky enough, as Robin's alluded to, that I've been involved with transplantation before I became a doctor even. So, I saw my father sort of going through this process with a lot of the faces that Brian mentioned in terms of Keith Hobbs, Ken Hobbs, Keith Rolls joining the unit. And Barry might not know this, but at one point I regarded him as my uncle when sort of I was called out, and it's an Asian thing where you have to show respect to the elders. So Uncle Barry was also there in some of the early days. What I'm going to talk to you about today is the current sort of transplant outcomes and where I see the limitations. I'm also just going to go over the transplant process, and that will just give an idea of the sort of patient journey, and you can get ideas as to where there may be limitations in that particular process. So we've been talking about liver transplantation, that's why we're here today. I suppose it's really important to know, why do we perform liver transplants? It's not because we can, it's because there must be some really key reasons for this. Patient benefit has to be at the end of this. So these are the four broad categories that I regard us needing to perform liver transplantation. To treat chronic liver disease, to treat acute liver failure, and to treat certain types of malignancy, and to replace livers with defective genes that can have an impact on the patient themselves. So in terms of chronic liver disease, this is really sort of manifest by a scarring of the liver itself. The term cirrhosis is used. And this is an irreversible process which has a major impact on the blood flow through that patient. It has an impact in the sense that patients start to get quite nasty symptoms that could be sort of considered minor if it was affecting us on a one-off basis. If you were tired or lethargic or developed itching in an afternoon, you'd just be pretty upset. But if you imagine that that was part of your life, you'd feel pretty miserable, and you may even get to the point of being suicidal with this. So although some people may smirk at the thoughts of people having transplantation for tiredness, itching, lethargy, this does become a major reason if you're that particular individual. The second thing that happens when you have a scarred liver is the blood flow around the liver and changes, and you get something called portal hypertension, a build-up of pressure around the liver. And the capillaries and the blood vessels in the abdomen start to leak, and you start developing a build-up of fluid in your abdomen, a term called ascites. And this can be miserable. It can start compromising how comfortable it is to breathe in and out. If you're carrying 10 litres of fluid sitting inside your abdomen, it can really have an impact on your quality of life. But really, you then go on to some real sort of risks to your life with severe complications. The ascites, the fluid in the tummy, can become infected, and you can get quite a nasty episodes of peritonitis. You may start vomiting blood. I mentioned that there's a build-up of pressure around the liver. Now, one of the ways in which this build-up and pressure of the blood supply around the liver tries to decompress itself is to find other ways to make its way to the heart, which is where the blood tries to make its way to. And you get dilated or congested blood vessels around the food pipe, the esophagus. And this can sometimes rupture, and you can have catastrophic bleeding from this, known as a variceal bleed. Another cause is that one of the functions of the liver is to break down some of the waste products from food, including the nitrogenous compounds that are present in proteins. And so if this isn't broken down because the blood is shunting around the liver and the liver isn't able to carry out its job, the nitrogen compounds may simply sort of cause the patient to become more confused, and this may deteriorate to coma, and so patients become encephalopathic. So these complications all tend to happen, and the way we see this on the liver unit here is, you may have someone just sort of pick it up incidentally with a problem, such as they may have vomited blood, and this may be picked up incidentally. But what happens is that they may start off with an occasional hospital admission, and then they have more frequent hospital admissions. So eventually, without transplantation, they're in hospital all the time. And they spend more time in hospital than outside the hospital with these life-threatening complications. So liver transplantation for chronic liver disease is has the fantastic capability of replacing the irreversible scarring of the liver, and it can have an impact on the quality of the life in the sense that the patients may not get the symptoms which some of us may consider minor: tiredness, lethargy and itching. It can resolve the ascites, and it can also prevent all of these life-threatening complications. The other main indication is acute liver failure. Now, this is predominantly an uncommon condition, but what essentially happens is it predominantly also affects young people. But there's a rapid deterioration of the liver function itself, and this could be for a number of reasons. Some of the more common reasons could be drugs. Paracetamol overdoses may cause this, but other drugs may also cause a rapid deterioration of the liver function itself. Also viral disease, hepatitis and inflammation of the liver caused by a virus. There's different sorts of viruses that can cause this. And these viruses not only can cause chronic liver disease, but can have an acute form of this where there's a rapid deterioration in the liver function. And this generally, when the liver stops working suddenly, there is uncontrollable bleeding and a rapid sort of progression of confusion to coma. Without liver transplantation, the mortality of this is extremely high, quoted in the region of 80%. But having a liver transplant can suddenly sort of turn us around by replacing the function, but they need to have a transplant within a finite period, and provided they get an adequate liver or suitable liver in that time and have their transplant when they're within the window of opportunity, as we often use, then they will unfortunately die. Now, malignancy is the third main indication for liver transplantation, and this is predominantly primary liver malignancy, so a tumour that arises in the liver from the liver cells themselves. And the indication really for liver transplantation is if we can't physically, as surgeons, cut this out safely, either because it's affected multiple areas of the liver or it's of a significant size, or the patient has a disease which is impacting the rest of the liver where they may be more susceptible to developing this. Also, if they do have portal hypertension in this setting, it may not be safe to remove this part of the liver itself. Metastatic malignancy was something that people had tried over the years in the past. So if patients had tumours elsewhere which had been removed, but then unfortunately they developed metastases or spread of the liver disease to the liver, then liver transplantation was considered in these cases. But this is now no longer deemed suitable. And one of the things which I'll mention later is there is a great pressure to use our finite resource, which is the donor liver. So there are some forms of metastatic malignancy, some sort of slow-growing tumours where the primary disease has been treated, and if there is malignancy within the liver, then that could be considered suitable for transplantation. But again, this is an area of debate, and even now in 2011 we are discussing the appropriate guidelines for this. Now, this is something that is quite interesting. The liver has many different functions, but one of the functions is to produce a series of different enzymes that help with the metabolism in your body. And the enzymes themselves, if they're defective or absent, may cause unusual diseases. So we have some patients who end up developing stones in their kidney and causes kidney dysfunction. And one of the ways to treat this is to not only carry out a kidney transplant in that patient, but to treat the liver disease and the defective enzyme by replacing it with a new liver that contains the enzyme. So an example is primary hyperoxaluria, where patients get stones in their kidneys which impact on this. There's also another condition where abnormal protein is deposited in the nerves because of a defective enzyme. And this is a condition called amyloid. This could also be replaced sort of as a crude genetic therapy to replace the defective enzyme by using a new liver. So these patients don't necessarily have portal hypertension and severe liver disease as such, and the liver looks and behaves otherwise in a normal way. And one thing, I'll mention this again later, is that sometimes because these livers look so normal, people have experimented with using these livers after taking them out of a recipient of a liver transplant and dominoing them into a second recipient, on the understanding that if it goes into an older recipient, they may not get that disease until they're perhaps 10, 15 years time later, when they may be quite a lot older, but we'll see them through sort of between the ages of, say, 60 and 70 at that point. So, in terms of the current outcomes, as Brian alluded to, it's improving over time. Chronic liver disease, the 1 year survival is roughly 90%, just under 90%. Acute liver failure is significantly less than this. There's poorer outcomes, 70%, but if you bear in mind that 80% of these patients are likely to die within sort of 24, 48 hours without a suitable liver transplant, then if you convert that to a 70% 1 year survival, if people were gambling, they really would like to take this particular gamble itself. And there's lots of different advances. The two which I feel are most appropriate is the advances in anaesthetic care. I'm really only saying that today because I can't see any anaesthetists here. If they were anywhere near us, I would have said that surgery is the #1 cause. And the advances in immunosuppression. So this is a slide which really shows the improvements over years, and this describes the era effect. So the pink line is the 1 year survival since the transplant, and this shows that it's roughly 65% between 1990 and 1992. But you can see that there's been a stepwise increase, if I draw your attention to that, to round about 85% at the last value. Sorry, I don't know if you can all see that. Oh, I thought I was about to take a penalty and someone was flashing a light at me. So here you can see it's sort of mid-80s in between 1999 and 2002. But the bottom line of this slide really is that the fact that with every era that's passed, there's been a sequential improvement in the 1 year survival. It seems to have sort of stuck round about the sort of 88 to 90% sort of point now, but we are looking to the future. We're looking constantly, and that's part of the reason why we're having these discussions and why we're looking forward today. So, this is essentially the patient journey when it comes to liver transplantation. They have quite a vigorous workup where we have to really look at the indications for that liver transplant. We have to ask ourselves the quite difficult question, is it suitable for this person to have a transplant? Do they justify having this liver, which comes from a very finite resource? Is it appropriate? Are they going to look after it? Are they going to abuse it? Are they fit enough? Are they likely to die following transplantation? And we've got some very difficult decisions to make, and this can be quite a laborious process, but it's a very, very important process. What we're also finding is that the indications for transplantation are also increasing. Okay, so what was considered inappropriate for transplantation 10, 15 years ago is now being considered appropriate. So patients who have co-infection of hepatitis C with HIV, for example, HIV would have been considered an absolute contraindication to liver transplantation only 10 years ago. But now it's becoming relatively routine to consider this as appropriate. Organ donation is a significant part. Brian's summarised his talk with where we're going. There's different forms of organ donors, DCDs, which is donation after cardiac death, and donation after brain death, which was really what facilitated the successful transplant program from 1983 onwards, and how we are trying to tap into these resources. The retrieval process is very important. I was up between 1 o'clock and 6 o'clock in the morning retrieving organs at another hospital. It's a laborious process, but it's a very vital process, and it's the essential process of transplantation. Without the donors, there is no transplantation. In terms of the recipient operation, I've mentioned some of the benefits and some of the key factors relating to the recipient operation, but this is where a lot of the focus has been on trying to make the advances. I think we've refined it as much as we can, although speaking to my colleague Corinci today, looking forward to the next 10, 15 years, he's telling me that there'll be robots doing the operation, so don't worry, Bimbi. Post-operative management and care, this is quite a crucial part of our transplant process. And, although I mentioned the recipient operation is quite crucial, patients are likely or at risk, not likely, are at risk of dying at any point after the transplant related to complications from the immunosuppression or indirect effects of the operation itself, and that can go on with them in the future. So this is essentially what a liver transplant looks like. Brian's already presented his case. This just shows that essentially it's a glorified plumbing job, as we mentioned. It's essentially 5 joins between the top of the cava, the bottom cava, portal vein, bile duct and artery. So technically there hasn't been too much change since the early days of transplantation. The benefits have come elsewhere, but I felt I had to show you a surgical slide as well as part of me being a surgeon. So this is my view of the limitations of the current process. I think it's fair to say that we don't know what the quality of the donor liver is going to be. So it's not sort of, let's go to Asda and pick off an ideal liver for my transplant on the top shelf or middle shelf, the bottom shelf. It's not a sort of price war. You don't get this. You get called in for your liver transplant, and there are certain risks associated with that donor liver. The donor, by virtue of the fact that they've died, has undergone a major metabolic process, which has killed them essentially. But the body has responded to try and keep that person alive with every possible means, sort of throwing every possible hormone, every possible sort of chemokine or activating factor which will protect all of the organs to try and keep that person alive. Now these may be great in life because they're trying to keep you alive, but they are very damaging to that liver. And so there's an injury that's happened during the process of that death. And there's no real way to assess this prior to retrieval. You can sort of look and speculate, and you can work out things as to how long that person's been on ITU, what the nature of the death was, whether they had infections, and we just can't really assess that. The next point to mention is that there is a real risk, because these aren't new livers patients getting, they're second-hand livers. Okay, there's a real risk of disease transmission. Okay, and when I say disease transmission, infections and cancers. Now, again, it's a very delicate and precarious balance. I was out between 1 o'clock and 6 o'clock at another hospital, and from this elderly donor, there was an abnormal lump in the liver, which essentially compromised whether we could go ahead with using this particular liver. So these are real things that are happening in 2011. In terms of organ preservation, the organ is flushed and cooled down, and the cooling process and the rewarming process injures the liver. If you sort of imagine, okay, and sorry to sort of become a bit base with this, if you imagine sort of defrosting your chicken for a Sunday roast, if you stick it in the oven straight away or put it in the microwave, actually you wouldn't do that for a roast, would you? It is obviously going to damage the organ and damage the chicken, so it won't function, and it will taste very different, and the function is very similar to that. Okay. I didn't time that in time for lunch. It's all right. Good. All right. In terms of the recipient as well, the cooling and rewarming with the blood subsequently can have a major impact on how that recipient does. Immediately, there's perhaps some toxins, is one way of looking at it, reactive oxygen species, free radicals, sort of nasty things which are going around trying to beat up the body, are hit into the circulation. And this can cause a significant impact on the recipient, even at the time of a successful, straightforward transplant. The other fact to watch is rejection of the liver. So our bodies are all primed to reject anything that's foreign in us. Okay, so if you put a new liver in, fair enough, it's being transplanted to save that person's life, but that person's immune system will try and reject that liver and beat it up from the very first moment it sees it. That is a major limitation of this. This has often been regarded as seen as the holy grail of transplantation, when we don't need to use immunosuppression and we don't cause rejection of the liver because the liver has some form of tolerance, or the host has some form of tolerance to the new organ. So the purpose of this slide is to really show, sorry, I'm aware that you can't see here, is to really show that the patients on the transplant waiting list are increasing, okay? But in terms of the transplants performed, and these are all transplants and these are all patients on the transplant waiting list, these are roughly staying the same. So going back from 2001 to 2010. And this just shows that the number of transplants is sort of up and down most years. Maybe there's been a slight trend of an increase in the more recent years, but generally speaking, this gap is getting bigger compared to this gap. And that reflects the increase in indications for transplantation, more people demanding transplantation, but the donor pool being relatively static. So the shortage of donor organs is reflected in terms of transplantation of there being a real risk of people dying on the waiting list. So getting onto the transplant list is one thing, but waiting for that organ is another. And there's roughly a 10% chance, a 1 in 10 chance that you'll die on the waiting list. There's also a chance that you'll become too unwell to carry on staying on that waiting list, and so you'll become untransplantable. So it's transplanting the person during their window of opportunity, which is the crucial limitation that I want to impress on you. So to prevent deaths on the waiting list, we're changing the nature of the donors on offer. We are using livers from older donors. I've already alluded to one last night that I went to. We're looking at donors after cardiac death, which is associated with increased risks in the recipient, in particular for the liver itself. We're looking at steatotic, which means livers that are infiltrated with fat, with more fat than you'd expect. We're looking at splitting the livers, as Brian has alluded. The domino livers was something I mentioned earlier on, of using a liver that's defective in that it produces an abnormal enzyme, and using that in the recipient to really treat that particular recipient, because it may treat them for a more critical pressing condition such as a malignancy. And we're also looking at using livers from people with diseases such as hepatitis or even malignancy, which sounds shocking, but we do deliberately on occasions use these because we know that the risks are less for the recipient. And living donation is also used to bridge this gap. This is really just to impress that the type of donors is changing. So this is all transplants, and this just shows what's happening in all transplants, including kidney. The number of living donors in the grey bars is increasing here, whereas the number of donation after brain death, which has been our traditional form of organ donation, is being reduced, and the donation after cardiac death are in the dark blue, and that's rising. Now, we've got serious concerns as a liver community about this form of donor because we know that they're not as good quality and they're associated with poorer outcomes, but the trends that are happening are particularly worrying, and this is something that's real, but this is something which we have to find ways to get around as a limitation. This just shows what a good quality liver looks like on the top shelf of ASDA, and this is one that you find on the bottom shelf, and this is one that's chopped in half, so it's a sort of buy one, get one free sort of scenario. So, organ preservation. The liver needs to be preserved and protected from when it's taken out of the donor to when it's put into the recipient. Traditionally, this was cold storage in preservation fluid. This is not an ideal setting. It's not obviously physiological, and the cooling process and rewarming injures the liver. And there's a limited time scale because even when it's cooled, the liver is still metabolically active. Okay, and there's a chance that the liver may stop working before it's implanted in the recipient. And in fact, there's times where the liver is implanted and it doesn't work at all, in which case that particular recipient needs a new urgent liver immediately. So, that person has received 2 livers from that finite donor pool. Rejection, different types of rejection, sudden and slow rejection. This damages the liver and eventually causes scarring if it's a slower form of rejection, and the liver may never work again, or may sort of slowly become dysfunctional and have similar problems that may have precipitated their transplant in the first place. So this is a significant limitation, a sort of chronic rejection that occurs. And immunosuppression, Brian's mentioned this, the main issue from this is that these do have quite powerful side effects. So infections, cancer risk, kidney damage. Infections because you're sort of damping down the immune response so that they're susceptible to all forms of infections, common infections, uncommon infections, bacteria, viruses, protozoa, weird and wonderful stuff. The cancer risk is because the immune system actually has a protective role in stopping you from getting cancer. So viruses can sometimes switch on the genes that cause cancers. So if you're immunosuppressed, you're increased risk of developing cancers. And kidney damage, some of these medications, tacrolimus, can damage and scar the kidney. So patients may be treated successfully with a liver transplant but may end up needing a renal transplant a few years later because of toxic side effects of the medication. So in this very brief overview, I've really gone through the indications for liver transplantation. I've talked about our current outcomes and the transplant process to give you an idea of the pathway and express what I consider to be the limitations of